not a process, it is a syndrome. And we have to look at it, I think, a little differently. I have no conflicts of interest, thank goodness. But what is vasoplegia? We know nitric oxide is involved. The other thing is complement. The entire complement cascade is entirely activated when this occurs. Why? Not sure, but it does. Endothelial dysfunction starts to occur, and you can measure that with various biomarkers we have right now, but selectins, P-selectins, E-selectins, MOUSE selectins, you name it, get activated during this process for reasons that are very unclear. And then there's this cytokine soup. Every cytokine you want to measure gets upgraded. IL-6, IL-1RA, IL-1, you name it, TNF, they go sky high. And why is that? I mean, why does this happen? You have 25 patients that get bypass and then this one. What's different about them? Well, the fact is we don't know. But just to make it easy, this is what it looks like. Right? Here's the problem. We have guanylyl cyclase, we have pro-inflammatory mediators, we have cyclic GMP, we have dephosphorylation and phosphorylation occurring. The adenosine type 2, which is near and dear to my heart because oh, geez. My God, I just ruined everything. Which is near and dear to my heart because I've studied it for years. But all of these things are activated during this phenomenon. And why this person? And that's what we don't really understand very well. The problem is this goes on to create acute kidney injury in most of those patients. And it does it because of these multiple systems, including endocrine, cytokine, complement, all of those vasoactive substances all go on to create acute kidney injury. Why does that matter? Well, it matters because of this. People that get vasoplegic syndrome don't do well. They do very badly. And they do badly because probably a multi-organ failure later. So for us as perfusionists, we think of it as a calamity of the operating room. But the problem is, look at 90 days out. So it's not just a calamity of the operating room. It's not a calamity of, just immediate post-op. But look at 2, 3, 4 months later, and it has a profound impact on outcome. And so this vasoplegic syndrome is not a post-operative issue. It's a long-term issue. And as an intensivist, I don't look at the first 24 hours. I look at 7 days out, 14 days out. And I'm still dealing with their kidney failure or their liver failure. And it's all because of what happened intraoperatively or perioperatively. And again, we don't understand it very well. This is the old paradigm. It's just nitric oxide, a little guanylyl cyclase, and a cyclic GMP, and it's over. And this was published about 10 years ago in a European journal, and this is what they said. It's just that simple. I'm here to argue that it ain't that simple, and I wish it was, because if it was, I could just block one of these, and I have tools to do that, and I'll show that in a second. The problem is, it doesn't work very often. And why doesn't it work very often? Because that's too simplistic of a model. And so about 10 years ago, I got involved in dealing with complex system analysis. And what that is stop looking at diseases or processes within medicine that I can go to one protein. if I block that protein, everything gets better. Well, that has failed every single time we've ever tried to do it, except for very specific diseases, like sickle cell or something else that's very peculiar, but this is not that. This is a systematic disease process. And so to think that I can look at it as, well, if I just block one thing, everything else will get better. And so with complex system analysis, what you do is you start looking at the process. This is a graph of, actually it's a very good graph that was done by a friend of mine in Chicago that actually looked at vasoplegia. And he looked at all the proteins that he could measure. What do you find? Well, I got all these proteins, but they all come to one node. And then this node goes to all these other nodes. And so it becomes kind of silly to think that if I just block this, all of this will go away. And we have to stop thinking in that process. And if you want to actually have a really good night's sleep, read this book. But it's actually an extraordinarily good book. And it really talks about medicine as taking it away from that one protein, one problem solves all. And start looking at medicine and problems in systems. Not in particular problems, but in system problems. We do it in medicine all the time. Our just previous talk talked about systems. You can't solve a single problem, you got to solve a system problem. Well, in medicine, in the molecular level, it's no different. You really have to look at it in systems. And so I look at this as really a series that you look at system science and system thinking. I do a lot of this. Unfortunately, I don't do a lot of this. And I need to do more of that and start thinking of this in system problems. I can think of it scientifically as a system problem, but when it comes down to bedside, I want to fix a problem. What's their blood pressure? What's this problem? And what happens is we can't do that. In particular, when talking about vasoplegia, because if you look at it, all of these things come down to intervention, and if you don't bring all of it together, you're not going to come up with a realistic solution. And so this is what system biology has taught us, is you have all these agents that are affecting a problem. The problem is they all have feedback loops. That's what we forget, is you affect one thing and you think, okay, I solved that. What we forget is for every gas pedal in medicine, there's a brake. And for every brake, there's a gas pedal. And if we don't solve both, we're not going to solve the problem. So we have to, if we have a stress and a common goal, we actually have to start addressing all these problems. And you have to do it all at one time. And so the way we've always looked at disease is you have an insult, you have a response, and you have a resolution, hopefully. What we forget, feedback loops. How many times does someone get better and then they get worse? How many times it looks like they're getting better and they crash and burn? How many times it looks like, oh wow, they're doing well and they don't do well? And it's because we forget about these feedback loops and this process that occurs all the time. And so we have to go back to this model, unfortunately, where you can't solve this node and solve this node without solving all these other problems. And so vasoplegia is a mass process of systems. And we can't solve it with one single intervention or multiple interventions. So why did we look at therapeutic plasma exchange? Well, one, is if you don't know about plasma exchange, there's two types. You can use a centrifugal pump, which just basically pulls out everything but cells, or a filtration system, which clears to about 2 million Daltons, clears everything but cells, and you get rid of all that plasma. Why would that be therapeutic? Well, what we started looking at was vasoplegia and start really marrying it to sepsis because it behaves like sepsis. I mean, it's refractory, it's hypotensive, they have super high cytokines, so why not look at sepsis as a model? So what we did in several studies, we looked at phenotypes of septic shock. And most people don't even know there's phenotypes of septic shock. And there are. Septic shock is not one process, it's many processes, and we're beginning to define them. One is a hyperferritinemic shock, and actually they get super high ferritin levels, and the iron process becomes very toxic to the body for reasons that we have no explanation for, but it occurs. And these patients do extraordinarily badly. And these are the ones that are on 3 pressors and die in hours. Why? We have no idea why, but we know it exists now. We also know that it's called macrophage activation-like syndrome. This is HLA or other types of autoimmune processes, and it behaves like that. It behaves like a very aggressive autoimmune process, but it's activated by sepsis. And then we have thrombocytopenic multi-organ failure, which acts like TTP. It's basically an Adams 13 blocking process that the body behaves like TTP. And it's extraordinary. We looked at this for several years. In fact, we just finished a multi-study trial with it. And it's amazing how many people have this thrombocytopenia, and everyone says it's DIC. Because that's an easy group to put them in. The problem is, it's not DIC. It's an Adams 13 deficiency process, and so it's a phenotype of shock. The extraordinary thing is, vasoplegia looks a lot like all of these. And the more you study it, the more it looks like all of these. TAMOF, you can see here, we just grouped it together. And you can see 2 more pressors. This is a patient that we had just a few months ago with hyperferritinemic shock. Ferritin level's 20,000. How many people measure ferritin? No one does. You don't do that acutely. But procalcitonin was also 1,800. We did therapeutic plasma exchange, and there was immediate drop. And you can see here, off pressors and discharged from the ICU in 4 to 5 days. Unheard of. And the reason is because we started looking at this from a systems biology perspective. And how do we affect so many things so quick? And we can only do it with plasma exchange. Why not just inhibit nitric oxide, which is what we do now, right? Methylene blue. The problem is, it's helpful and harmful. It's like almost all things. You think you're helping, but you're really hurting. But you're not hitting it from a system. You're hitting it from a specific process, not from a system process. And this is a great paper out of Europe, and it really looked at 15 years of methylene blue and said, one, sometimes it works, sometimes it don't. Why does it work sometimes, and sometimes why doesn't it? And we don't know. I think it's probably phenotypes of vasoplegia. That's probably very specific to the patient. And some patients respond well to nitric oxide inhibitors and others don't. And it comes back to that simplistic model I showed earlier. this is what they're explaining is, I just get this guanylyl cyclase and everything gets better. Unfortunately, that's about 10% of patients that actually have vasoplegia. So there's phenotypes of vasoplegia that we just don't understand very well. And that's what we are trying to address. And again, it goes back to this model. How do you affect this? But you have all this other stuff. So it's almost naive to think if I affect this one little area, that the rest goes away. When I really need to start probably doing all of these. I have to block all of these probably at one time to really make a difference. So why use plasmapheresis? Why use therapeutic plasmapheresis? Well, one, we think it addresses many nodes. Remember that graph I showed you? We can remove a lot of things that are bad. We remove a lot of things that are good. But we think that removing the bad is better. There's more bad than good, so we're removing it all. We address multiple nodes. But mostly, what we think is occurring is that we're doing the unburdening effect. That you have all of these inflammatory processes coming down on you. We know that you have the capacity to recover from that and adapt to that, but the process becomes so overwhelming that your body can't have that recuperative capacity. And so one of the things we think is occurring with this is the unburdening effect. And so that's the hypothesis. Again, what we're trying to do is not address these, which is what a lot of times we have done, but really start addressing these nodes. And can we affect these bigger nodes and affect more things at one time than we could with individual therapies? And again, if you get back to this vasoplegia, what we're trying to do is affect all of these at one time. Instead of address one thing individually, do it all at one time. And if I take all that other stuff away, look at these arrows and feedback loops. There's no way that one intervention is going to probably work. And so we have to do something that I think affects a lot of things. So we did what we usually do is we did 5 cases. We didn't pick 5 cases. We just presented this at the Critical Care Conference in San Diego. But we just did our first 5 cases. And they had to have a criteria. And they were refractory on 3 pressors, so they're on epi, levofed, vasopressin, whatever, but we're still hypotensive. They had to fail methylene blue. So they got methylene blue and didn't respond. They were oliguric, which is common, and one of the biggest issues with vasoplegia is that renal failure, and that component becomes very bad for reasons that we don't understand, but it is, you need to make urine. I mean, your body wants you to make urine. They had to maintain a cardiac output, meaning that even in spite of these pressors, they maintain their cardiac output. We just did that so we didn't try to suppress cardiac output. And there was no history of ACE use before. So we were fortunate we got 5 within a couple of months. 4 were off vasopressors in 6 hours after TPE. So what we did is we put in an Aldol, did a therapeutic plasma exchange, a simple plasma exchange, which is 1.2 times their plasma volume, and 4 were off pressors in 6 hours. That will get your attention. The one that wasn't off in 6 hours was off in 12. None required renal replacement therapy, and all went home. I don't know what your experience is with vasoplegia, but this raised our head and said, this is something we really got to look at. So what we're thinking right now as far as vasoplegia, and I'm recommending this as a sole provider of this, is methylene blue is first line. We don't know where angiotensin II is going to fit in as a new vasopressor, but it probably doesn't have use here. But I am going to start recommending TP as a rescue. That if you have someone, they failed methylene blue, they're still hypotensive 4 to 5 hours later, really look at therapeutic plasma exchange because it does address those multiple nodes. It does address the multiple issues that go into vasoplegia, and it's simple to do, very simple to do. It beats renal replacement therapy. It beats, dialysis 5 days from now. And I think it's something that we really need to look at, particularly as a perfusion community, start recommending for our providers that, look, they're crashing, they're burning, it ain't working. Why not plasmapheresis? It's easy to do. We have multiple reasons why it should work. And we hope to have this published in the next couple of months. So you'll have a little backing. But I just want to present this early to the group. So.